Now that we're in a situation where oil prices are down, we're a bit cost constrained, we might be threatening a change in services, we have to remember that the cost to Alberta of stroke is probably 300 to 400 million per year. And that's in direct and indirect costs, all right? So I think it's really, really important to keep that in mind. The average cost at a year for a single patient is 80,000 to 100,000 and probably 40,000 at 6 months. So there's a big cost to the disease, so we still need to do this stuff to improve the quality of treatment and maximize the value of our treatments. And we made a lot of progress in the provincial stroke strategy, increasing the number of centers across the province that could give clot-busting drugs, which you all know about. But what we struggled with, of course, was the purple line here, which is door-to-needle times for stroke, which we really had a tough time getting under 60 minutes. And even after 2011, where this graph leaves off, it probably went up higher still after that across the province, which is why quicker is so important, and it gives you the history of just how effective quicker has been, because we now have an unheard of drop in door-to-needle times. So I bring you back to this graph that I like to present, which is the timelines in TPA use. And basically, the CT scan is a major factor which can sometimes introduce delay, because it's an essential part of the process that you can't do without. And of course, if you spend extra time on every step, you can prolong door-to-needle times by 90 minutes in a tertiary care center, and the same situation in a rural center where you have the same number of steps, but just different kinds of steps. Okay, you have telehealth and video conferences, whereas in a tertiary care center, you have a stroke fellow calling their attending physician, but there's a lot of stuff that's the same. And in case you are new to the collaborative, you can't get by without a CT scan, because although this is a subarachnoid hemorrhage from a ruptured aneurysm, you can usually tell this clinically from a stroke. Nobody can tell this thalamic hemorrhage from an ischemic stroke syndrome. All right, so the CT scan will always be an essential part of the acute thrombolysis process. So you've done your CT scan, and as we've talked about before, it isn't enough just to do the scan there. It does have to be pushed to the telestroke neurologist. And so we've talked previously about how to do that, and it is really important that we get those plane scans first, all right, that we get the plane axials first. The axials are the ones that we use most. Those need to go through, because it'll take those anywhere from usually 3 to 7 minutes, sometimes longer, to go through the internet to actually get to the impact server where I can see them. All right, so if you bundle it all, if you wait till the CT angio is done, there may be delay. And if you bundle all the films together in a massive CT angio file, it actually may take a lot longer for that massive file to make its way through the system. All right, so those first plane axials are really, really important. And of course, the CT angiogram, all right? The CTA speed's highly center dependent, but as Michael has said before, and as we've put in the algorithm, ideally the first scan is a CT scan plus a CT angiogram, all right, almost always. If you can do it within minutes, and that's your metric. If I can do a CT followed by a CT angio within minutes, it makes a lot of sense. And the reason is because by the time those images get to me, the plane scans get to me, and I look at them, it's at least 5 minutes. And you can do a CT angiogram in 5 minutes if you're fairly quick, all right? So that's what we actually advocate, that both are done with the first imaging modality. So I'm going to structure the rest of the talk into questions, and we're going to go through the questions to see if we can answer some of them. So the first question is, when do I let CT know about an acute stroke? ASAP, because they'll be able to schedule. They appreciate that. They appreciate knowing as soon as possible about the patient, because they can schedule the patient in amongst other patients. And it's the same thing probably in Foothills and at the University Hospital and at the Grey Nuns. With pre-hospital notification, ideally, which most of you guys now have down to a science, but just to formalize it, ideally, if you've got a callback situation after hours, you want to let your CT tech know as soon as you have pre-hospital notification. And then again, as soon as the patient arrives in the ED, because once they've arrived, they're going to be scanning within minutes, so they need to organize themselves ASAP. Especially if you're at the Grey Nuns or the U, or maybe in Red Deer and Grand Prairie, where the CT scanner might be used for other patients or a trauma or something else. If you let them know again ASAP, don't just leave it at the pre-hospital. They'll be able to organize themselves to be able to scan your patient as quickly as possible. All right. All right. So the next thing is, So if you can't actually notify with pre-hospital, then failing that, you need to have multiple steps where you've checked to see if CT's been notified. And if they haven't, then you notify them again at that step, okay? And the patient arrival is really, really about as late as it gets. All right, so Steve arrives at a primary stroke center where the in-house technologist can do a plain CT scan. There's a callback needed for a CTA technologist. Since CT plus CTA is the new standard, do we wait for the CTA tech to arrive before proceeding with both? So the nice thing about this talk is we've answered all the questions now, which is great. It's review, right, as part of the previous discussions that just happened kind of on a random basis. All right? So yeah, so it's good to review it, and the answer is you do the plain CT scan immediately, if you can, and then you do a callback, and as soon as the CT tech comes in, that's when you do the CT angio, okay? And then we'll work on the so-called red referral process as we go, and then we'll figure that out in terms of whether we're going to transport or launch a plane without the CT angio done and then stand down, or what we're going to do. We'll have to sort that out. But if you can't get the CT angio up front, we're going to thrombolyse, and then we're going to see where the dust settles afterwards. All right, so in regards to advance notice, this CT tech received advance notice, and this CT tech did not receive advance notice. Okay, and this has been my personal experience, actually, because at the U, and I'm sure at Foothills, those CT technologists, I mean, we do not give them donuts and, that fruit with the chocolate you can get from, I can't remember where it is, and they make it look like a nice design. We're not giving them enough of that stuff because they are so busy, and they accommodate us so much, and they try to drop stuff to do CT imaging as fast as they can. And the thing is, I mean, if you don't give them enough notice and it's, we got an acute stroke right now, it's outside the door, I mean, that doesn't go over. That doesn't go over well. They'll accommodate to it, but really we need to give them as much notice as possible, okay? So it's important to do. And they have a technologically complex job in terms of windowing CT angios and everything, so I think the notice is appreciated. All right, so as I mentioned in the first thing, most TPA decisions can be made on plain CT. We like to have a CT angio. There's a certain proportion of patients that are very diagnostically confusing. Like, for example, the patient with the seizure at onset that might have had focal symptoms prior, but you're not really sure from the history. And when you arrive, the seizures stop, but they're hemiplegic. And you're not sure about a hyperdense MCA sign because of the density of the MCAs on both sides. You're not really sure. If you saw a big blockage there, you'd probably thrombolyse that person for sure, right? So there are situations where the CT angio makes a difference. And if I had my ideal situation, I'd get it done in every patient prior to lysis, but that isn't often how it works. So we do the best we can. And then the other question is CT angio required every time pre-thrombolysis? We just answered that question as well. So I guess this is another question we've already answered, so this will be a quiz. All right, so Steve's plain CT scan's finished. The techs are able to do a CT angio. Should they wait until all the CTA images are post-processed before sending the CT and CT angio images to PACS in one big file? Who says no? Everybody by now. Great, that's perfect. Okay, so the answer is no. Acquire and push the axial plane images first, and then acquire and push the CT angio source images. And then if you can do the MIPS, fine, but the source images are what we look. We look at those axials, and we make decisions on transfer from those axials. Those are what we look at first off. And those are often the only scans we have on telestroke. At the time we have to make a transport decision, we often don't have the coronal and sagittal MIPS and all those other things, so we look at those axials right off the bat. So what is this stretcher to CT business? And I think now we've also answered those questions a lot. So following the swarm, the patient goes to CT in the EMS stretcher without pausing much in the ED. And there's data from Foothills DTN project that stretchers to CT can actually save up to 20 minutes. And there's other data in the literature that says the same thing. All right, and the next question is, will they be giving TPA in my CT scanner? And the answer is maybe. So at the University Hospital, we're struggling right now with stretcher to CT because, and we just actually got it formalized and implemented just like literally 2 weeks ago. And the reason we're struggling is because there's no place to really swarm in the front door entrance so we go to trauma to swarm. And then we want to thrombolyse on the CT scanner. So that's what we like to do. So what we do is we do the plain scans a lot of the time. We immediately mix TPA in the scanner. We give the bolus. We complete the CT angio, move the patient back, and continue the infusion within minutes back in the trauma bay. And this is our process that we've used. What we're finding is stretcher to CT is kind of pushing off the stroke fellow's NIH stroke scale. So we have to now, we have a fellow who hasn't examined the patient, and they're on the CT scanner. And so then we can shoot a CT, but we have to move them back to trauma before we thrombolyse. So we're finding that we're struggling right now with the best way to use stretcher to CT. But most places across the province will benefit from a stretcher to CT. And in some situations, the next question is, will they be giving TPA in my CT scanner? Well, maybe. It all depends. I mean, if you go stretcher to CT in a primary stroke center, it's probably unlikely that you're thrombolysing in the scanner, right? Your CT scan's done. The images have to be pushed. The telestroke neurologist has to see them. I have to talk to the doctor by phone and then by video, and then we'll give TPA. All right, so you CT techs who don't want, who are nervous about TPA being given in your scanner, you don't have to worry about it. Having said that, it's not a big deal. We actually give it in the CT scanner all the time. And it mixes up very, very quickly, and we give the boluses very fast, and it doesn't seem to be a burden for the CT techs at all. They seem to be perfectly fine with it. And then we move them again back to the trauma bay to finish our infusion, all right? So what about multimodal imaging? So this is probably a long ways off for most rural primary stroke centers. And also, in some cases it's useful. We use perfusion CT when we're treating late patients, all right? So we look at the flow defect here and the actual area of blood volume interruption here, and we have a mismatch pattern. It's not so clear-cut as the image shows you. It depends on how you define the delay. So there's some technical issues too in terms of how big this area of mismatch is. But we use this a lot in Edmonton because we're getting people from Fort McMurray. We're getting people from high level, and they arrive late. They arrive at 10 hours. They arrive at 9 hours, way beyond the usual window. And so we do use perfusion imaging sometimes to make late reperfusion images. We also use CTA source images, which are used in ESCAPE as well, all right? So you probably won't be doing this in the rural primary stroke centers anytime soon. If, as people spoke to me about, if you can get the thick MIPS, actually done and sent with the images, it's actually an easier CT angiogram to look at. But the telestroke group, at least in the north, is used to making a lot of decisions just looking at axials, because those are what are available, okay? So I think I'm going to pass over the algorithm, because we've already looked at it. Basically, you do the CT angio as fast as you practically can, all right? But you don't delay thrombolysis to actually do that. So the things here that you want to do prelytic are the things in black for sure. And the things that you don't have to do necessarily prelytic are the ones in blue, okay? So there's certain things that you can actually do away with, but obviously any of the imaging is not actually something you can do away with, all right? Think about mapping. You really have to go into the details, all right? So I visited Grand Prairie and I found it a very useful exercise to actually talk to the CT technologist, the chief technologist, the radiologist, and the emerge docs to figure out exactly what the process was. I think now, through the iterative discussions we've had, we kind of have a very good approach, which we might not have had even 6 months ago. So I think we've worked out a lot of the process flow issues, but if you're finding that there's still delays, process map it. Get everybody in the room to figure out where these roadblocks are actually happening, okay? And again, go for the goal. These are our pins. We wouldn't function without them, so. All right, so basically, don't forget about the cost to stroke. There's cost to CT angios, there's cost to having techs on call, but it pales in comparison to the cost of stroke to the province right now, okay? And even in times when oil prices are low, stroke will be no less expensive, okay? So we have to deal with it. All right, thanks a lot. Thanks to the whole Quicker group.